right, now I haven't been traveling much over the past couple of years here during the pandemic, and I've been doing most of my presentations through Zoom, but I decided to make a trip this time, coming up to San Francisco and spending a day with the UCSF endo residents, and also talking about endo. I also get a chance to speak to the program director, Elisabeth, who's an excellent endodontist and researcher. Now, I had a great time. These residents were extremely courteous, nice, and very intelligent, and I had a wonderful time. And I've kind of been motivated now to get back on the road and do more presentations, specifically for the endo residency programs around the country and also even internationally. If you are interested in having me present at your endo program, please email our educational coordinator at info@rebuildendo.com, and I would possibly come over and give a presentation at your endo program, and I get a chance to see your place and your city and your country, and or wherever you are, and also make a little video about it. But on a more serious note, since I'm actually here at the hotel room, I figured I'll make a quick video also to discuss an interesting article that was brought up to my attention by one of our followers, Dr. Maharaj, who was kind enough to share with me this article regarding a case of an overfill of a cement into the inferior canal causing paresthesia for a patient. Now, in the article, they don't mention actually what specific cement it was, but it was one of those injectable cements. It was a bioceramic. So nowadays, there's so many different bioceramics on the market. Probably should make a video to distinguish about some of these and some of the differentiation between them, but they're obviously not all the same. But either way, the idea of having a cement, any kind of cement, whether it's biocompatible like a bioceramic, or more neurotoxic or cytotoxic, such as a eugenol-based cement or a epoxy-based resin, into the inferior canal can cause two different kinds of injuries. One is a chemical injury that is a basis of whatever kind of chemical you're introducing into that space that could cause neurotoxicity. But there's also a specific amount of compression that is caused by the cement that sets that prevents that puts compression and pressure on the nerve that could cause different forms of injury to the nerve in that point as well. It's also important to realize that most of these cases that are done with injuries are related to also having an open apex, which is related to prior to the injection of anything inside that outside the root is potentially also involved with the injection of hypochlorite or over-instrumentation. So not only just the cement injury of the radiopaque material you see, but the injury that occurred beforehand by the files, as well as any of the hypochlorite and other potential caustic irrigation materials that may have extruded but may not be radiopaque. But just going back now, assuming that it is caused by any kind of an injectable cement, we need to understand that the hydraulic condensation technique that we at Rebuild Endo have developed and discussed for the longest time, we've always emphasized the importance of using the direct injection technique if you actually have a microscope, so you can see how much you're injecting and how much you're not. If you don't have a microscope, the best way to at least to introduce the cement to the canal for hydraulic condensation would be in a traditional manner by placing the cement, injecting the cement onto a paper pad, taking it with a file and introducing into the canal. You can put the file in reverse direction in about 300 to 500 RPM. So it's not like a lensular spiral that is going at a very high speed, but it's very slow at 500 to 600 RPM in a counterclockwise direction. And then you've got a percha cone and you slowly cement it into that. But the placement of the file in a counterclockwise direction is it makes sure that all the canal walls are coated, and then the additional cement on the gutta percha cone can additionally fill in any potential gaps that could be present. So keep that in mind. The injection of the cement directly into the canal should only be done if you have some visual microscope to be able to see what you're doing, so you're not over-injecting or under-injecting. The other problem here is that oftentimes people who use the injection tips lock the needle into the canal. Whatever you're doing, whenever you're locking the needle in the canal, you would be exceeding the pressure in the canal compared to the potential apical resistance pressure that is present at the apex of the root. And whenever that happens, whether you are irrigating with an irrigation solution, or if you're injecting sealer into the root canal, you're going to get an extrusion. And the way we always talk about prevention of the hypochlorite accidents is the same exact way you would be preventing the overfill and over extrusion of cement if you're injecting directly, by making sure that your needle is not locking into the canal and it's loose the whole time. And that's another one of those reasons why the minimal waste tip was developed to be completely parallel and very thin at the very tip, so there's enough room for the cement to flow back up around the tip. If you're placing a taper tip and locking it into place and injecting, that would be very, very unsafe. Also, what you want to do is before you take the sealer into the space, you want to make sure you inject a little bit outside so that the sealer is at the very tip of the needle before you introduce the needle into the canal. This way, when you're pressing, you know that there is sealer coming out. Oftentimes, people don't realize that there is sealer coming out and they're over-injecting and they don't know there's already plenty of sealer that's come out. That is one way to completely avoid that problem so that you're not over-injecting. So these are some of the simple tips that you could use to help avoid any potential overfill inside the canal. That could be as small as a puff or as large as a serious case of injection into the sinus or into the infraavicular nerve, and that should be avoided at all time. Remember also, when you're doing your case selection, it's also important to recognize the presence of these kinds of vital structures in the area. So if you're not having a scope, for example, you would know that this is not a case you want to inject directly. You want to make sure in these types of cases, especially lower second molars and so on, and the maxillary molars, that you are then not injecting directly, but rather just placing this, coating the file, and then coating the walls, and then following with the coated gutta-percha cone to cement into place. I hope this was helpful to you. Obviously, at all costs, we want to avoid any kind of potential injury to the patient. That runs all the way from our instrumentation, access and instrumentation methods, all the way to irrigation, and of course, obturations, all the same. The potential for an iatrogenic error that could be costly to the patient is always there, and we should be always cognizant of the environment and the surrounding and the anatomical limitations that we have in the space that we're working, and how we can potentially avoid problems for our patients. What I'd like to leave on one of the big quotes from one of our program directors, one of the original program directors at Harvard Dental School, and the program was Dr. Krakow used to say that never leave a patient worse off than when you found them. And that's really a critical component and a philosophical insight to keep in mind by being more careful and avoiding any potential problems whenever you're treating your patients. Alrighty, guys, don't forget, if you're interested in having a talk at your residency program, give us a quick shout out, and if you have any questions or additional things, write it down below in the comments area, and I look forward to seeing you in the next video. For Real Dendo, here from the beautiful city of San Francisco in California, I'm Ali Nasseh, and let's save some teeth.